Welcome to the 340B program, a pharmacy overview. My name is Mark Kinney. I'm the Executive Vice President of Government Relations for Independent Pharmacy Cooperative. Also joining me today is Paul Karch, Executive Vice President at Independent Pharmacy and General Counsel, and also Kate Health, who's the Sales Director for USave Pharmacy Group. And today we want to talk a little bit about the 340B program and see if it's the right business solution for you. I want to start also with a brief background on it. The program was created in 1992 as part of the Veterans Health Act. And the intent of it was to enable local healthcare providers known as covered entities to stretch precious federal resources. And what that's really allowed them to do is expand healthcare services in their local communities. The program is run by an agency called HRSA, which is part of HHS. And HRSA is the Health Resources and Service Administration Agency. In addition, in 2010, the ACA expanded the program even further. And one of those key components was allowing covered entities to contract with more than one pharmacy. And along with some other provisions, the idea around ACA was to expand the 340B program. And in fact, that's exactly what we saw, because shortly afterwards, the use of 340B in communities across the country started increasing, pretty significantly. And if you look at the last, 5 or 6 years, the program has really expanded. In 2022, the sales around 340B was $54.6 billion, and that's at the discounted rate. At the retail rate, those sales would approximate $126 billion. So anytime you see those kind of dollars out there, it generates interest by different groups. And one of the groups is Congress. The Senate is looking at 340B very, very closely. There's a group of senators from Wisconsin and South Dakota and other rural states that are looking at this very closely, and they're referred to as the Gang of Six. It includes John Thune from South Dakota, likely successor to Mitch McConnell, who obviously will be playing a very important role out in Congress. And he's one of the senators looking to lead the charge on reforming 340B. As you might imagine, the manufacturers also have taken an interest in how big the program has grown. And because of that, they've unilaterally placed some restrictions on covered entities, including going back to the one-to-one pharmacy relationship, as well as taking some drug product items and making them unavailable under the 340B program. That caused some concern within the states, and states now, their legislatures have now taken action around that with manufacturers, and Arkansas and Louisiana were the first two states that really came out and passed state laws saying that the manufacturers cannot interfere with the covered entities, business partners, and contract relationships. Since then, other states have followed, and I think 20 states now have either passed laws or are in the process of passing laws. And the most recent, Minnesota, just recently passed a law just within the last 30 days. All these laws center around kind of the business relationship and making sure that manufacturers are not interfering in that business relationship with the covered entity and their partners. Paul, do you have some, with all the changes that we're seeing, what's the legal landscape?
Sure, thanks, Mark. So when you have a lot of money at stake and a vague statute, it gives rise to litigation because people object to how things are working and want to see it differently. So as Mark mentioned, when the program greatly expanded after 2010, some of the manufacturers said we want to go back to one-to-one, and HHS, HRSA, originally provided guidance that said, no, you can't do that. You got to allow as many pharmacies as the covered entity wanted. And so there were a couple of court cases, or several court cases about that. So this is the first attempt was HHS trying to force the manufacturers to allow many pharmacies for a covered entity. And two U.S. Courts of Appeals in the District of Columbia Circuit and the Third Circuit have said, nope, 340B does not authorize HHS to do that. And that's because kind of a quirk really in 340B for a statute that affects so much money. Usually when there's a statute like that, especially in healthcare, there's specific regulatory authority given to HHS or somebody, CMS or someone, to adopt regulations to implement. Well, there is no such authority here. And so HHS originally said, well, if there's no authority, it must mean we can do it. And the courts have said, no, actually, if there's no authority, that means you can't do it, cannot do it. And so the manufacturers have the freedom to maneuver, basically. At least HHS can't stop them. So as Mark pointed out, so if HHS won't do it, how about the states? Can the states regulate what the manufacturers are doing in terms of number of pharmacies? And states have passed laws, and those have been challenged. So far, the only case that's gone really far is the Arkansas law, and the manufacturers argued that Arkansas law was preempted, that is kind of overruled by federal law. And the courts have said so far, including the Eighth Circuit, which is an appeal from the Arkansas federal court, said, nope, you can't. There's nothing in this statute, and it's a more complicated argument, but basically said the federal law does not overrule the state law. So the current state of play is the federal agencies don't have any authority to force more, to require manufacturers to sign up more pharmacies. But so far, it's been allowed that the states do have that authority, which is partly why they keep passing laws to do so. So that's kind of, I think, the state of play here.
Great. Thanks, Paul, for that overview. And with all that said, Kate, perhaps you can address what this means at that community pharmacy level and what it means for our pharmacy members.
Yeah, thanks, Mark. So there's really a lot of ways I think that we can ultimately take this conversation, because 340B really has been in the news and in so many different aspects. But Mark, one of the things you talked about in the beginning was the manufacturer restrictions. And I think that's probably a really important place to start, because if you are a contract pharmacy or a covered entity, that's been probably the first impact that you ultimately have felt as it relates to these manufacturers putting certain restrictions in place. So to give a little bit of an overview of that, a lot of the manufacturers within this space have restricted the number of contract pharmacies that can ultimately dispense 340B drugs on behalf of that covered entity. So essentially, that's really meaning that that covered entity is going to be limited to using only a couple pharmacies or one pharmacy to be able to dispense a particular 340B drug and have that contract pharmacy relationship. I think a really important distinction here, and to understand from a contract pharmacy perspective, is who is your contract with today? Is it a critical access hospital? Is it a federally qualified health center, FQHC? The reason it's important to understand those differences is each class is impacted differently as it relates to these restrictions. So a lot of the time, if you're looking at a critical access hospital versus an FQHC, critical access has had a lot more limitations put on them versus an FQHC. So that's a really good area to understand as it relates to what your contract looks like. The other thing that's really important about these restrictions to understand is when they're putting them in play, each manufacturer looks at these restrictions in a different way. So most of the manufacturers today are now requiring that the covered entity submits data claims to verify 340B eligibility that they will ultimately be selling these drugs at that 340B price. So if you're a contract pharmacy and you're noticing that lesser and lesser claims are qualifying for your particular program, there's two things at play here. First, either the covered entity hasn't designated you as their primary pharmacy, or second, that covered entity is not submitting or keeping up with the claim data submission process that the manufacturers require. And so as a result, you're not seeing a lot of that 340B pricing trickling down, which is ultimately impacting that contract that you have with that covered entity. So if you as an owner are seeing some of these things, it's really important to speak up and ask that TPA vendor, whether it's a MAC or Helix or a PDMI / that covered entity contact that you're working with, to make sure things are really flowing correctly. So everybody, both the covered entity and that contract pharmacy, is getting what they should be getting from that particular program.
Great. Thank you for that. At this point, anything else, Kate?
I would say, Mark, a really important area to also look at when it comes to contract pharmacies is how they're evaluating signing those particular contracts. So in a lot of conversations that I've had is a contract pharmacy gets approached by a covered entity and they're like, great, let's go. We want to get this contract in place. And for the most part, a lot of the times it is benefiting both parties because, again, it's supposed to be that overall source for that community to stretch those scarce federal resources. So when it comes to actually evaluating a contract, there are a couple of things at play in really important areas to look at. I usually look at them in about three. So the first is, what type of model are you signing up for? Usually there's either the adjudication or the replenishment model. A lot of the times what we recommend when it comes to these pharmacies is staying on that replenishment model, sort of as a pay as you go. So as you're utilizing that particular drug, it's being paid for, versus the adjudication model, you're paying up front. And that's going to cause an issue with cash flow as you continue utilizing the program in that particular contract. So that's number one. Number two is understanding what that dispensing fee structure should look like. We've seen a lot of changes as it relates to the DIR fees with independent pharmacy. And so a lot of the times now that we're seeing that DIR fees at the point of sale, it's important to have a structure from a dispensing fee standpoint that can help or take some of those things ultimately into account. A lot of the time, it's important to have some type of a percentage and a flat fee associated with that particular dispensing fee to help offset some of those differences there. The last part is just understanding, are you going to be signing a brand only contract or are you looking at a brand and generic contract? There are a couple factors that go into ultimately making that particular decision. But a lot of the time, if you're looking at a brand only contract and you have some type of a GCR component with your wholesaler, that's ultimately going to better support those economics, as it can increase what that GCR looks like from the wholesale side. If you are looking at a brand and generic contract, there's a lot of conversation that needs to be had both with you at the contract pharmacy side, but also at the covered entity side, because there are ultimately going to be more scripts that ultimately are flowing through the program. And it's just good to look at from a compliance standpoint, what policies and procedures are in place at the covered entity side to make sure everybody is within compliance for that particular program. So those are the three I always say to look at, Mark, is the model, the dispensing fee, and then what type of structure, being brand or brand and generic.
That's great information, Kate. Thanks for sharing that with us. At this point, I want to thank Kate and Paul for participating in the discussion today. We'd encourage all of our members to reach out and contact USave Pharmacies and Independent Pharmacy Cooperative if you have any other questions. And of course, we'll also be available at IdeaShare in New Orleans coming up in a couple of weeks. To answer any questions, please stop by the booth, talk to Paul, Kate, or myself, and make a determination if 340B is the right business solution for you. Thanks everyone for listening.
Thanks so much.